hypertensive retinopathy occurs due to hypertension, no brainer. Hypertension, what does it do, everybody? It does, number one, vasoconstriction. Yes? So there is a vasoconstrictive phase, first of all. Blood vessels constrict. After that, there is what, everybody? Atherosclerosis. So there is sclerotic phase. Focus on the word atherosclerosis. See, this is not specific to the eye, everybody. This is everywhere in the body. Hypertension is a systemic phenomenon. Atherosclerosis means deposition of a plaque in the lumen of the artery, which leads to narrowing of the artery. Yes? Narrowing will lead to less blood flow forward. Less blood means less oxygen. Less oxygen means hypoxia. Hypoxia leads to release of VEGF. VEGF leads to neovascularization. Same fundamental, guys. And due to the atherosclerosis, there will be exudation from the blood vessels. So we are calling it exudative phase. So this is how hypertension proceeds everywhere in the body. Yes? Based on this, everybody, and based on the similar pathogenesis as diabetes, we can study the clinical features. Clinical features are discussed under a classification which is popularly Keith-Wagner classification. Even as third year MBBS students, guys, I hope we have encountered this name. This is a very common question to be asked in third year in vivas as well as in theories. Keith-Wagner says that the findings in hypertensive retinopathy can be divided into 4 grades. Grade 1. In grade 1, what is being seen? The vasoconstrictive phase. Vasoconstrictive phase means due to hypertension, as a response, all the blood vessels are getting constricted. So what you end up seeing is arteriolar attenuation. Arterioles, which are small vessels with narrow lumen, they are getting constricted, so they are almost getting closed. Closed means attenuated. We say that the normal AV ratio in terms of diameter is equal to 2:3. Arteries have narrower lumen than veins. But in hypertensive retinopathy, this AV ratio diameter decreases to 1:3. Okay, that's the way we recognize a vasoconstrictive phase. That's the earliest finding in hypertensive retinopathy also. In grade 2, now atherosclerosis has started to occur. Due to that, you see a named sign. What is that sign known as? Sallu's sign. Instead of Sallu's sign, I call it Sallu's sign to be able to remember it. If you know Salman Khan, everybody, Salman Khan in the Bollywood industry is popularly known as Sallu Bhaiya. So remember Salman Khan sign or Sallu's sign. Yes? Now grade 3. Grade 3, the atherosclerosis is continuing, giving rise to 2 other signs, which also Salman Khan helps us remember. Sallu sign, Salman Khan ने गाड़ी के bonnet पे bonnet sign, gun रखा, gun sign. Okay, everybody? Salman Khan ने गाड़ी के bonnet पे रखा gun. Salman Khan has kept a gun on his bonnet. So this way you are able to remember that Sallus will always come first, and the other 2 names are bonnet sign and gun sign. Now what is Sallu's sign, what is bonnet sign, and what is gun sign? So let's remember B for B. Bonnet is banking of a blood vessel. You understand banking means sloping, everybody? Gun, everybody. If I draw a gun for you, this is basically a revolver or a gun. If I draw a crude figure, a gun is never straight, everybody. It has a taper. Yes or no? So I remember gun sign is tapering of a blood vessel, whereas Sallu's sign is deflection of a blood vessel. So once you are able to remember B for B, bonnet is banking, gun is tapering sign, Sallu's becomes deflection. So deflection is occurring of a blood vessel, banking is occurring of a blood vessel, that means sloping or complete tapered out. Okay, everybody? This we can remember. But what we need to understand is, these changes, everybody, deflection, banking and tapering, are seen at AV crossings. Are seen at arteriovenous crossings. In arteries or veins, see, arteriovenous crossing means there are 2 things, artery and a vein. So these signs, this deflection is of an artery or a vein. Banking is of an artery or a vein. If we go by common sense, we would say hypertension is affecting the arteries. But actually these signs, this deflection, this banking, everything is occurring in veins. Why is that so? Very simple to understand. Sclerosis, atherosclerosis is leading to rigidity of the artery, everybody. Yes or no? The artery is becoming rigid. Below the artery, the soft vein is passing. So now the rigid artery is compressing the vein, which is leading to deflection or banking or complete tapering. Are you understanding? So in the sclerotic phase, due to rigidity of the arteries, the veins is getting compressed, everybody, and they are showing these kind of signs. Am I clear to everybody here? No confusion. So please remember, these are AV changes characteristic for hypertension, Sallu's bonnet and gun. In grade 3, simultaneously exudative phase starts. When exudative phase starts, everybody, exudation, that means leakage is occurring, hemorrhage is occurring. What are you able to see? Flame-shaped hemorrhages with cotton wool spots. Okay, everybody? Simultaneously, the vasoconstriction is proceeding. Yes? So the vessels are getting much more constricted. They get to be known as copper wiring of arterioles. Are we clear, everybody? Grade 3. Now, let's move on to grade 4. In grade 4, what is occurring, everybody? Instead of copper wiring, we are saying there is more constriction. So now the arterioles appear absolutely empty of blood. So they give a silverish, whitish reflex, silver wiring of arterioles. And classically, the patient has papilledema. Papilledema means edema of the optic disc, swelling of the optic disc also. Okay, everybody? So these are the 4 grades. Please remember them: 1, 2, 3, 4, constriction, sclerosis, and exudation after that. As simple as that. If I show you a photograph now, everybody, focus on that photograph at the top. What are you able to see, everybody? Let's see. First of all, let's see the white arrow, everybody. At the white arrow, what do you see? You see a hemorrhage. Yes or no? You see a hemorrhage. What shape of an hemorrhage? Flame-shaped hemorrhage. So the white arrow is the flame-shaped hemorrhage. Now let's see the black arrow, everybody. At the black arrow, we are able to see a pale yellow large collection which looks like a cotton. Yes or no? So this is a cotton wool spot. We know this. But flame-shaped hemorrhages and cotton wool spots can also be seen in diabetes. Why it is a case of hypertensive retinopathy? For that, look at the box. In the box, what do we see, everybody? We see that the artery is going. And below that, if we see, we are able to see the deflection of the vein. If we carefully note the vein, everybody, the vein is coming, then dipping down and then coming back up again. Yes, I'll just clear it for you, everybody. Now that you know it, probably you will be able to notice this. This is the subtle change that we need to notice, everybody. The artery going, vein dipping in, coming out. Arteriovenous change. I don't expect you to answer whether it is Sallu's bonnets or guns, but at least you should be able to answer that it is an AV change. So along with cotton wool spot, flame-shaped hemorrhage, AV change makes it grade 3 hypertensive retinopathy. Am I crystal clear, everybody? Yes? Let's see another photograph. Let's see this photograph. In this photograph, what do we see, everybody? At the blue arrow. At the blue arrow, we see a cotton wool spot. Cotton wool spot. This again, we see a cotton wool spot. Yes? Now focus on the optic disc. Are you able to see any margin of the optic disc at all, everybody? No. So there is swelling of optic disc. Yes? Papilledema. Also, if we look at the macula, we see exudates. In what kind of an appearance, everybody? Macular star appearance. Yes? We've already read the causes of macular star, everybody. I hope you will go back to it. You will be able to remember this macular star appearance. We have read it in neuro-ophthalmology. Macular star is seen in cases of neuroretinitis also. There we have listed hypertension also as a cause. But which hypertension, everybody? It is specifically a case of malignant hypertension. Macular star exudation is seen in malignant hypertension. Malignant hypertension along with swelling of optic disc makes it grade 4 hypertensive retinopathy. Am I clear to everybody? Malignant hypertension can only occur in grade 4 after everything is crossed due to severe rise of hypertension. Am I clear to everybody? So you can even tell the grade of hypertensive retinopathy if you apply your mind to it. Again, you have to just see the anatomy, what is occurring in the optic disc, what is occurring in the macula. You have to see the blood vessels and all the lesions along with it. Right, guys? That's as simple as hypertensive retinopathy. Just some names: Keith, Wagner, Barker. What are the names? Salus, bonnets, guns, copper wire, silver wire. That's it about hypertensive retinopathy. Nothing more to it, everybody. Done? Let's start with the next pathology now, everybody, in vascular group of disorders: central retinal artery occlusion, or popularly short form CRAO. I don't think I need to go into the pathogenesis. Retina, artery getting obstructed, no blood flow, hypoxia, VEGF, neovascularization. Yes? I will straight away jump to what are the causes. Why is the central retinal artery getting obstructed? Number one, the most common cause, everybody, is atherosclerosis. Just like in hypertension, if there is complete occlusion or partial occlusion of the central retinal artery due to atherosclerosis, we will call it CRAO. Secondly, everybody, apart from this atherosclerosis, what other phenomena can lead to any artery occlusion? Yes, all of us know that. A thrombi, when it breaks, is known as emboli. Emboli can transfer anywhere. Yes, so emboli. There is a specific type of emboli, guys, that we should be aware of as far as the name is concerned. This is known as Hollenhorst plaque. Hollenhorst plaque is a cholesterol emboli which originates from bifurcation of common carotid artery. Okay? So it starts from bifurcation of common carotid artery. I hope after that you understand. From common carotid artery, internal carotid artery, from that into the ophthalmic artery, and the branch of ophthalmic artery is central retinal artery. So from here it will travel up to here. Am I clear to everybody? So if you know the blood supply, if you know the branches, everybody, as we have already discussed various times now, we should be able to understand this. Please remember the name Hollenhorst plaques that is used as part of MCQ sometime. The third important cause is giant cell arteritis. Yes, a large vessel inflammation, vasculitis, everybody, affects the temporal artery, giant cell arteritis. Yes, these are the three common causes. There can be thousands of other causes. I hope you understand anything which can obstruct a vessel, which can form a thrombi. So if I say what is the most common side effect of oral contraceptive pills, we know thromboembolic episode. So that can also lead to CRAO. So similarly, we have to think about it. Any coagulative disorder, all of those can lead to CRAO, but these are the three most common presentations. Right? Now, after we know the common causes, we need to know the clinical features. Number one, when the artery gets obstructed, obviously, absolute hypoxia will ensue. So there will be loss of vision. But the loss of vision will obviously be sudden and it will be painless. Please remember, we are talking about an emboli or an atherosclerotic event. We are not talking about an inflammatory event. So it will be painless and it will be sudden. As soon as the artery gets obstructed, there will be no blood, there will be hypoxia, and it will lead to sudden visual loss. That is what usually the patient will complain of. Secondly, everybody, because this is a retinal disease, this retinal disease can lead to optic atrophy. As we already know, all retinal diseases can lead to optic atrophy, which is consecutive. Thirdly, we again know that because the retina will lose its blood supply, the nerve fibers will lose their nerve supply. The optic nerve will also get affected partially, leading to the classic RAPD or Marcus gun pupil. This has already been understood in neuro-ophthalmology that partial diseases of optic nerve or diseases of retina like CRAO, retinal detachment, everything can lead to RAPD or Marcus gun pupil. Fourth, everybody, fundus appearance. When you look at the fundus, what will you be able to see? Number one, because the fundus is losing its blood supply, everybody. Yes, what is ensuing, everybody? Exudation. All the blood vessels are now undergoing the dilatation. Yes, so there is edema. Edema is leading to a pale fundus. When there is no blood coming, everybody, as a response, the blood vessels start to dilate, leading to retinal edema, leakage of fluid. And due to that edema, everybody, you can't see the red color coming from the choroid and the fundus becomes pale. Are you able to understand this? Retina is transparent. That is why the fundus appears red in color due to the choroid color. But when the retina will become edematous, edematous means hazy, it will hide the red color of the choroid coming from behind it. Secondly, we say cattle tracking fundus due to segmentation of blood column. Very easy again to understand, everybody. Let's say this is my artery. This is where it has been blocked. So posterior to the block, distal to the block, everybody. Now the blood is not flowing anymore, but the artery is continuing its pumping action. So what do we see? We see that there is a little bit of blood. Then the blood vessel is empty because the blood has been pumped out. Then there is blood again. Then again an empty blood vessel. Then again there is presence of blood. So it looks as if cattle has walked over my artery. So wherever cattle has kept the foot, the blood has vanished. Then there is blood. Then blood has vanished. Then there is blood. So segmentation of blood column due to no blood flowing and the contractile action of the artery. Am I clear to everybody? So known as cattle tracking fundus. Done? After this, everybody, the characteristic thing that we all are aware of, I hope, cherry red spot at macula. Cherry red spot at macula. Yes or no, everybody? That's a classic finding. Now the question comes, why does cherry red spot occurs? Why does cherry red spot occur at the macula? I have seen a lot of students answering because macula has a dual blood supply. That is an absolutely wrong answer. Cherry red spot occurs at macula due to collection of fluid in ganglion cell layer of retina. Now this ganglion cell layer, everybody, as we already know, or I think we should know, is absent at foveola. So basically what is occurring? If we try to understand, the whole retina is edematous. I can say hazy. Yes. If the whole retina is edematous or hazy, what we are able to see? Pale fundus as choroid red color is not visible due to retinal haze. Okay? But foveola remains transparent. As ganglion cell layer is absent at foveola, so there is no edema. So foveola remains transparent. Because foveola remains transparent, everybody, that is why I can say the choroidal red color is visible at foveola. And this red color that is actually visible at foveola gets the name cherry red spot. If you try to understand, everybody, 99% of the retina is opaque. So red color is not visible in 99% of the retina. But the red color is only visible in the center of the macula, center of the fovea, that is foveola. And that is why that appears red. So the red color of the cherry red spot is actually the normal part of the retina. The rest of the retina is pale. The rest of the retina, everybody, is the part which is abnormal. If we see a photograph now, everybody, let's see this photograph. What do we see, everybody? Look at the macula. Everything is pale in the macula. Only the center of the macula is appearing red. Cherry red spot at macula. Surrounding this, everybody, all this is now pale retina. Am I crystal clear, everybody? So the simple fundamental of why my fundus appears red, the same fundamental, retina remains transparent, it will still appear red, but if the retina becomes hazy in the surrounding, it will become pale. So please take home message, cherry red spot is the normal piece of retina, surrounding that it is the abnormal retina. Am I crystal clear, everybody? No confusion about this? Done? Okay. Now, let me show you another photograph and ask you the diagnosis. Let's see this. So I will say figure 2. What is your diagnosis in this case? What is your diagnosis? Obviously, we are discussing CRAO, so you will be tempted to say CRAO. But is it CRAO? Is it CRAO? If you look at it carefully. When you are looking at this image, you you are focusing on this part. I know you are focusing on this part. Why are you focusing on this part? This is also CRAO, guys. Why is it CRAO? What do we see everywhere? There is no red color. It is completely pale. Only this part of the retina is normal. Why, everybody? If you remember cilioretinal artery, in 75% of the cases, cilioretinal artery, branch of posterior ciliary artery, supplies the macula. So from the optic disc, everybody, the macula is still getting supplied. So these blood vessels are not affected. This part of the retina is not losing its transparency. And if you see at the macula, obviously dark brown color is seen. I know it's not absolutely a red color. So obviously it depends on the quality of the photograph. So this is a cherry red spot. Am I clear? So this is CRAO with macular cilioretinal artery spared. Okay. See the corresponding FFA, everybody. When I see the FFA, what do I see? That none of the blood vessels has filled with dye. Because there is central retinal artery occlusion, there is no blood in any of the blood vessels. So there is no dye, everybody. So no dye in any blood vessel. But we see the dye filling which? Dye filling cilioretinal artery. I hope I am clear here, everybody. So this confirms that this is a case of CRAO, central retinal artery occlusion. Only the cilioretinal artery is supplying the macula. Am I clear to everybody? So there can be various presentations of the same case. I hope you are able to understand this. There should be no doubt. There should be no confusion about this. Done, everybody? Now, I move back to cherry red spot. We see that cherry red spot is occurring at the macula due to problem in the ganglion cell layer. Why does cherry red spot appear cherry red in color? We have explained it. But if we have read biochemistry, have we heard the name cherry red spot before today? Yes, we have. At lots of places, Niemann-Pick, Tay-Sachs. That means cherry red spot is not specific to CRAO. So what is the differential diagnosis of cherry red spot at macula? This can be remembered through a mnemonic. It's a very old mnemonic. I've just modified and made it a little better. Cherry trees never grow tall in sand, mud and grime. So I've just extended the mnemonic a little. Causes of cherry red spot, the mnemonic starts with cherry, very easy to remember. Cherry trees never grow tall in sand, mud and grime. Dhool, mitti or kichad. Okay, let's see. C for what we are discussing, CRAO. T for trauma. Please remember specifically blunt trauma. N for biochemistry now, everybody. Niemann-Pick's disease. G for gangliosidosis type 1. T for Tay-Sachs disease. Sand for yes, Sandhoff's disease. If you know biochemistry, Tay-Sachs and Sandhoff's are types of gangliosidosis type 2. M for metachromatic leukodystrophy. And the last G is the famous name, Gaucher's disease. Okay, so these are all the names. I hope you are noting down the list. Cherry trees never grow tall in sand, mud and grime. The first two are ocular causes. Rest all other causes, everybody, are biochemistry or storage disorders. Okay, clear? Please remember, pediatrics books say, even Nelson's pediatrics textbook, O.P. Ghai, both of them say that Gaucher's disease does not present with cherry red spot. I am telling you that Gaucher's disease presents with cherry red spot. Why is there a confusion? Gaucher's disease is of 3 types, type 1, type 2, type 3. Type 1, there is no cherry red spot. Type 2 cherry red spot is present. Type 3 maybe. Which is the most common type of Gaucher's disease which presents in infancy? Type 1. So pediatrics says that because type 1 is the most common and in type 1 cherry red spot is absent, so it says Gaucher's disease cherry red spot is absent. But we say type 2 it occurs, so it is actually a cause of cherry red spot. So you have to read the question carefully when it is asked and then you have to answer. If all the options in the question are correct, then Gaucher's disease will be the wrong answer. Are you getting what I'm saying? So let's say question number 1, everybody. All of the following are causes of cherry red spot except. Options given are CRAO, blunt trauma, Tay-Sachs, Gaucher's. Are you getting the question? Listen to the question again. All of the following are causes of cherry red spot except A, B, C, D. All the 4 according to the list are true. In such a case, the answer becomes Gaucher's because we can say it is the least prominent cause. Are you getting my point, everybody? So please read the question carefully. If there is an absolute wrong cause given, then mark that, otherwise mark Gaucher's disease. Such questions are very common. They have been asked in the past, they will be asked in the future also. So please remember this confusion about Gaucher's disease. Am I clear to everybody? That's all about cherry red spotted macula. These are all the important clinical features of a case of CRAO. Now, once we know that CRAO presents with such and such features, we have been able to see the fundus, we have been able to diagnose, then we need to treat CRAO. So the first thing I want to remember is that it is an ocular emergency. I know if I don't treat it as an emergency, ischemia will ensue and the retina will not be able to regain its function. So the first question that comes into my mind is, treatment should be done within first 4 hours. Okay, everybody? That is the time when you start the treatment, is most successful. Within 24 to 48 hours, everybody, occlusions become complete. Okay? So the maximum window we have to be able to salvage something is 24 to 48 hours. Ideally, the treatment should start within 4 hours. Otherwise, the patient will lose a chunk of his or her vision. Now, what is the treatment we institute? Number 1, the first thing that you need to do, although controversial, is ocular massage. It is postulated to help in dislodging the emboli. Okay? Basically, what we are doing massage. See, when I am doing massage, I am pressing the eye. So I am pressing the blood vessel. I am pressing everything. I am pressing the blood vessel. So the blood vessel is getting compressed. I will massage for 30 seconds, then I will leave. So the blood vessel will now expand. Okay? I will again massage, compress, expand, compress, expand. So basically by this compression and expansion, I am trying to dislodge the emboli. Jhatka de rahe hain, if you try to understand in one way. Are you getting my point? Secondly, everybody, we know that if there is an emboli blocking the complete blood vessel, if I dilate the blood vessel, now if I dilate the blood vessel, everybody, the blood will be able to flow around the emboli. Okay, everybody? So what I need to do is vasodilatation. What is the fastest acting vasodilator, everybody? We should know from our pharmacology. Sublingual. What sublingual? What sublingual? You need to know this. This is a very important drug in the arsenal, everybody. If anybody is having a stroke, a heart attack or anything like that, you need to know this. Sublingual isosorbide nitrate. Please remember this name. Don't say nitrate. Don't say nitroglycerin. You need to know the exact compound to be able to save the life of a patient. Okay? Sublingual isosorbide nitrate. Or the second way is to let the patient inhale a gas mixture which is called as carbogen. Carbogen is constituted with 95% oxygen along with 5% carbon dioxide. 5% carbon dioxide will cause hypercarbia. Hypercarbia means partial pressure of CO2 will increase. This will lead to, everybody, decrease in pH. Decrease in pH will lead to vasodilatation. Thus, we are basically causing respiratory acidosis. And respiratory acidosis, everybody, is known to cause vasodilatation. Done, guys? Thirdly, everybody, apart from vasodilatation, we have to decrease the intraocular pressure. See, the pressure inside the eye is compressing all the blood vessels. We need the blood vessels to dilate a little. So we are decreasing the pressure to allow the blood vessel to dilate a little. Now, we already know the fastest way to be able to decrease the IOP is to administer intravenous mannitol. We have already seen during the chapter glaucoma, everybody. Or what can be done in emergency cases is paracentesis. Paracentesis. I hope we know this much of our medicine. We have attended simple postings at least. That we know that the treatment of ascites is paracentesis. So basically what is paracentesis? Withdraw fluid, aspirate fluid. Yes? So just like we can aspirate fluid from the abdomen, we can aspirate the fluid from the eye. Which fluid? Aqueous. So once we are aspirating the aqueous leads to IOP. Once we decrease the volume of the aqueous, we are basically decreasing the intraocular pressure. So aspiration of aqueous. I hope there is no confusion in this. Okay? This is your emergency treatment. After you have been able to do the emergency treatment, then you need to find out the cause, then you need to administer, let's say a tissue plasminogen activator, TPA or something like that. You need to do, embolectomy or whatever, everybody. Yes, thrombolysis, everything like that. So after this becomes a case of being able to diagnose the event, a cardiovascular event or whatever that is, and then treating the event. Emergency treatment to save the vision, to be able to give the retina a chance to salvage itself, is this emergency treatment. I hope I am clear about CRAO. There should be no confusion about it. Very simple pathology. Please remember cherry red spot as a specific sign, and please remember the photographs and the fundamental of the pale appearing retina due to edema. Okay, everybody? That's all about CRAO. Now we start with our next disorder in this group. That is central retinal vein occlusion. Yes? CRVO. Instead of the artery getting occluded, now we are saying the vein is getting occluded. What is the most common cause of CRVO? The most common cause of CRVO, just like CRAO, is hypertension. There are various other causes, but this is again the most common cause. For the purpose of treatment and our understanding, we divide CRVO into two stages. Non-ischemic CRVO and ischemic CRVO. We can say there are basically two continuous stages. First of all, non-ischemic stage will occur and then ischemic stage will occur. Let's try to understand. Non-ischemic stage, all the changes occur due to stasis of blood. I hope you are able to understand stasis. See, what is occurring? There is an artery. After that, there is a capillary network. So I'm just drawing it like this. And after that, there is the vein. Okay? Because there is a block in the vein, everybody, the blood is not able to flow. When the blood is not able to flow, there is stasis of blood. There has to be a continuous flow from artery to vein, to artery to vein, to artery to vein. This stasis is leading to what, everybody? Old blood in the artery, capillary and vein, everything. So there is no new blood which is coming. No new blood means no new oxygen. No new oxygen means hypoxia. Also, because the blood is not able to flow, everybody, what occurs? Increased vascular permeability. Yes? There is stagnancy of blood. This stagnancy leads to separation of plasma and all the blood mass. This increased vascular permeability, everybody. Understand, the vessels are not damaged, they are only permeable. Permeability means the fluid will leak out. This fluid leaking out will lead to macular edema. That is the most common significant presentation in the non-ischemic stage due to stasis, macular edema. And already all of us know, everybody, macular edema leads to loss of vision. If we jog our memory back to the mnemonic for the risk factors or cystoid macular edema, the mnemonic was run for pride, R for RVO, retinal vein occlusion. Yes? So this macular edema leads to loss of vision. So if somebody asks you what is the cause of loss of vision in non-ischemic stage macular edema, because loss of vision is occurring, that's why I need to treat it. Now treatment options through diabetes, if you jog your memory, we already know photocoagulation, anti-VEGF drugs or steroids, triamcinolone. Here, the preferred treatment is, everybody, intravitreal triamcinolone. Okay? Or what we can do is, everybody, we can implant 0.7 mg dexamethasone intravitreal implants. So there have been various studies, everybody. This was told to us by the Geneva study. The Geneva study told us that the implant is better at working rather than the triamcinolone injection actually. Or what can be done? Anti-VEGF drugs. Ideally, even though it is the non-ischemic stage, the pathogenesis of an ischemia disorder. So as we noted, in any kind of ischemic pathology, everybody, we tend to prefer injection of steroids for the treatment of macular edema. And that is why the answer is either a triamcinolone or a dexamethasone 0.7 milligram intravitreal implant. I hope we are clear about this. Yes? Now, the hypoxia which was occurring, everybody, the hypoxia ensues. Hypoxia becomes severe. When hypoxia becomes severe, everybody, it starts to damage the blood vessel wall. Yes? Due to no nutrition coming, due to no metabolism occurring in the blood vessel wall. So there is damage to capillary endothelium. As soon as I write damage to capillary endothelium, I hope again diabetes rings into your head, everybody. Damage to capillary endothelium will lead to leakage. Leakage will lead to hypoxia. So the cycle will become vicious. So due to this damage to capillary endothelium, what are the clinical features? Number one, everybody, there are severe flame-shaped hemorrhages. Severe flame-shaped hemorrhages. There are so many hemorrhages that the fundus gets a name. The name of the fundus popularly is known as, everybody, yes, I know you are saying tomato ketchup or tomato splash appearance. There are so many hemorrhages that all you can see on the fundus is hemorrhage. So it looks as if somebody has splashed a tomato over the photograph of a fundus. Okay? Classic name, everybody. I'll just show you the photograph so that you know. Can you see, everybody? You can only make out the optic disc. Apart from the optic disc, everywhere you look in the fundus, khoon hi khoon hai yaar. Yes? Tomato splash or tomato ketchup appearance. Apart from tomato ketchup appearance, the second finding that you will see in the ischemic stage will be rubiosis iridis. Now, what do you mean by rubiosis iridis? First of all, then let's get into understanding why it occurs. Rubiosis is derived from the word rubor. Rubor means red. Red means blood. Blood means vessels. Yes? So, iris becomes neovascularized. Neovascularization of iris. Now, this is a sign I am telling you. Now, the question is, why have I not written the sign as neovascularization of retina? Due to hypoxia VEGF, neovascularization of the retina should have occurred. Yes, it is occurring, but I am not saying it is a sign because I can't see it. Why can't I see it? I can't see it because of this. Because the whole retina has so much of hemorrhages over it, even if there is neovascularization, I won't be able to see it. Yes? But what will I be able to see is rubiosis iridis. Now, why does neovascularization of iris occur? Try to understand it as a story. My retina is becoming completely hypoxic. So, my retina does not have enough oxygen to carry out its function. So, my retina is saying to my iris, you are also vascularized, you have oxygen. I can't function anymore. So, please give me some of your oxygen. Please give me some of your oxygen so I can function. Iris says, okay, we are of the same eye. I will give you some of my oxygen. So basically, the hypoxia of the retina or the posterior segment is putting a demand on the anterior segment. The anterior segment oxygen is going to the posterior segment, and thus the iris, the vascular tissue in the anterior segment is becoming hypoxic. Iris has no pathogenesis. Iris has no kind of leakage. Iris has no stasis. But the iris is helping the retina. That is why it is becoming hypoxic. And because the iris is becoming hypoxic, neovascularization is occurring at the iris. Are you able to understand? So rubeosis iridis occurs due to oxygen demand by posterior segment. Are we clear about this? Yes? Now, once rubeosis iridis occurs, everybody, then the story is different. Rubeosis iridis means neo vessels. Neo vessels means leaky vessels. So these leaky vessels will leak into the anterior chamber. Leak blood in anterior chamber. When blood leakage occurs in anterior chamber, everybody, it blocks trabecular meshwork, causes neovascular glaucoma. Okay, I hope we are clear about it. Yes, when we were reading secondary glaucomas, we had said that other glaucomas can also occur, and I am teaching it to you related with retina now. Yes, neovascular glaucoma in CRVO occurs after around 3 months. That is why known as, popular name everybody, I hope you know this. Questions have been asked left, right and center on this. 100-day glaucoma. So second name question everybody. First name question is tomato ketchup or tomato splash appearance about ischemic CRVO, and the second is 100-day glaucoma. It is nothing but just as I have explained neovascular glaucoma, it occurs usually around 3 months after that. So 3 months is approximated as 100 days here. Am I crystal clear everybody? Done? No confusion? Now, please remember neovascular glaucoma. The most common cause is diabetic retinopathy. Neovascular glaucoma can also occur in diabetic retinopathy, and the most common cause is actually diabetic retinopathy. Diabetic retinopathy also presents with hypoxia in the posterior segment. So the same fundamental will ensue in diabetic retinopathy also. Yes? No confusion? Now if you ask me, sir, what is the treatment of ischemic CRVO? What is occurring in ischemic CRVO, everybody? What is the word we are again and again saying, everybody? We are saying damage to capillary endothelium leading to leakage. So for leakage, everybody, what do we need to do, everybody? Pan-retinal photocoagulation. Pan-retinal photocoagulation. Please don't get confused. Rubeosis iridis is occurring on the iris, but there is no problem in the iris. The problem is actually in the retina. So unless you treat the retinal hypoxia, rubeosis iridis will keep on occurring. So we don't need to treat rubeosis iridis per se. We need to treat the CRVO ischemia on the retina. Pan-retinal photocoagulation, just like diabetic proliferative retinopathy. Am I crystal clear, everybody? And that's all about my CRVO. Please remember the two different stages. Non-ischemic, there is no blood leakage. There is only increased vascular permeability leading to edema of the macula. But in cases of ischemia, there is blood, so there is hemorrhage, there is rubeosis iridis. Done? No confusion? Now, as a variant of CRVO, we should also be aware of this kind of a photograph. What do we see in this photograph, everybody? We see that all this area, everybody, is showing you hemorrhages. Yes? Just like CRVO. Can I say so? But only a certain part of the retina. So can you call it partial CRVO? Obviously. So instead of that, I call it BRVO. Branch retinal vein occlusion. Superior branch of central retinal vein has been occluded. So only the superior part of the retina has been affected. Okay. Two questions are asked. Number one question is, what is the most common site of occlusion? So the most common site of occlusion is at arteriovenous crossings. And secondly, what is the most common quadrant affected? So the most common quadrant affected in BRVO is superotemporal. Apart from that, everything remains the same. Am I clear to everybody? So no new disease, just a partial form of CRVO, you can say. Right, guys? Done? So that's our fourth condition completed in vascular disorders, everybody, CRVO. Let's move on to the fifth condition, everybody, important condition, that is known as retinopathy of prematurity. Short form ROP. Retinopathy of prematurity. Yes? So we are saying there will be certain changes in the retina which will occur in a premature child. Premature are hypoxic, Yes or no? Every child who is born premature is hypoxic at birth. That is why RDS occurs, respiratory distress syndrome. What does my retina need? My retina needs hypoxia to cause neovascularization. Yes, guys? Right. So, I will teach you in the question answer form. Question 1. ROP can occur in. Does it occur in all premature children? No. So, we have to define which subset of premature children. Answer. If age at birth is less than equal to 32 weeks. Okay? Age at birth is less than equal to 32 weeks. Or if birth weight is less than equal to 1750 grams. Am I crystal clear? These are the two subsets of premature children which are candidates for having ROP. Again, I am saying these can have ROP. I am not saying they will have ROP. Because they can have ROP, I need to examine. So now the second question comes. Age of screening for ROP. Meaning what? If a child is born today, everybody, when will I screen that child? When will I examine the retina for presence or absence of ROP? Do I examine it today, tomorrow? When do I examine it? Yes? So, we have guidelines for this. If age at birth greater than equal to 28 weeks and birth weight greater than equal to 1200 grams. Okay, everybody? In this case, we will do the screening 4 weeks after birth. Okay, everybody? Second scenario. If age at birth is less than 28 weeks, or, that's the most important point to note here, or birth weight is less than 1200 grams. See, what am I asking you to note? That in the first criteria we have written and, that both the age should be greater than and the weight should be greater than. If any of the two is less than 28 or less than 1200 grams, we have to do the screening 2 to 3 weeks after birth. Am I clear? So, if the child is born less than 28 or less than 1200, we are calling it a more severe case. So, more severe case means the pathogenesis or the signs and symptoms may develop earlier. So, we are screening slightly earlier. Am I clear to everybody? So, you need to see the age, you need to see the birth weight, and you need to answer the question. Okay, question number 2 done. Now, third question, everybody. When we are examining, when we are screening, what are the signs we will be able to see? We should be aware of the signs. So, what are the signs? Or I can say the stages. Okay. So, the stages have been divided by the International Classification for ROP, ICROP, into 5 stages. Okay. Let's see, everybody. Stage 1. In stage 1, we see a demarcating line between vascularized retina and the peripheral avascular retina. Okay. Because the child was born preterm, the periphery of the retina remained avascular, whereas the central part of the retina had vascularized. So you are able to see a demarcation line between the two. In stage 2, everybody, we see a ridge. This demarcating line, everybody, turns into a ridge. Ridge means a slight elevation. In stage 3, there is what, everybody? There is extra retinal neovascularization. There is extra retinal neovascularization on the ridge moving into vitreous. Am I clear? The ridge becomes neovascularized and the vessels seem to be jumping into the vitreous. In stage 4, retinal detachment occurs, but it is partial, whereas in stage 5, total retinal detachment will ensue. Okay? So very small way of remembering the stages. Demarcation line, ridge, vascularized jumping into the retina, total RD and partial RD. Am I crystal clear, everybody, about this? These are the stages of ROP. Let's see the images, everybody. Let's see the image at the top, everybody. What do we see? That this part is the central vascularized retina. Yes? Because of the preterm birth, this part has remained avascular. Now, between the two, there is a small ridge which has formed, everybody. Yes? It's a small elevation. Obviously, it is difficult to make out the elevation in a 2D photograph. But yes, after a little bit of experience, I can tell you that this is a ridge which has formed. Okay? Now see the photograph. What do we see in this photograph? In this photograph, again, we are able to see the ridge. But we see that the blood vessels have climbed over the ridge, everybody. So this is stage 3, when there has started occurring neovascularization over the ridge. Am I clear to everybody? Done? So simple photographs. Now, once we've answered these 3 questions, we know it is a case of ROP. We need to treat it. So the treatment obviously had to be what? Laser photocoagulation. Because we know that ROP is causing neovascularization, the treatment has to be laser photocoagulation. Okay? Or what can be done, everybody? Pars plana vitrectomy. If RD or retinal detachment has already taken place, stage 4 or stage 5. Focus on laser photocoagulation. When is laser photocoagulation done? It is done if pre-threshold ROP type 1, as told by ETROP study. Okay? Now, what is pre-threshold ROP type 1? If zone 1 is affected plus any stage, along with that, we are labeling the disease as a plus disease. Or zone 1 is affected and specifically there is stage 3. Stage 3 means neovascularization. Or if zone 2 is affected, along with that it is either stage 2 or stage 3, a ridge or a neovascularization of the ridge, and it is a plus disease. In any of these 3 scenarios, we call it pre-threshold ROP type 1 and we treat. Now, all this must be looking or seeming alien to you, I know. Let's first answer, what do we mean by a plus disease? ROP is said to be ROP plus or a ROP plus disease when there is venous tortuosity and dilatation in greater than equal to 2 quadrants. Okay? As I've already said, venous tortuosity or venous dilatation, venous bleeding, venous looping are signs of severe hypoxia. So, if I divide the retina into 4 parts, everybody, if this is my retina, I divide it into 4 parts. In any of the 2 parts, I see venous dilatation and tortuosity. I will term ROP as a plus disease, first of all. Stages we already know. 1, 2, 3, 4, 5. Now, let's move on to the zones. For description of signs, we divide the retina into 3 zones. Everybody, let's see this. Zone 1. From the optic disc, we draw a circle with 4 disc diameter. 4 disc diameter is equal to 6 mm. This is called zone 1. Optic disc and 6 mm around it, 4 dd around it. Okay. Zone 2. From the boundary of zone 1, extending up to the nasal ora serrata. Extending up to the nasal ora serrata. We again draw a circle. The remaining part, everybody, which is seen only temporally, is called as zone 3. I don't think anybody is going to ask you what is zone 1, zone 2, zone 3, but still you should remember. From the optic disc to 4DD, zone 1. From zone 1 to nasal ora serrata, zone 2. And the periphery is zone 3. Okay? Figure is drawn, nobody is going to ask you this. Now let's see, everybody. So if I say that ROP is present in zone 1, around the optic disc in the center, any stage it may be, whatever stage, 1, 2, 3, 4, 5, I'm not bothered, and it is a plus disease, I will treat. Or I will treat if it is zone 1, but specifically it is stage 3, plus is not necessary now. Am I clear to everybody? Zone 1, neovascularization, stage 3. Or if it is zone 2, it is either stage 2 or stage 3, and it is plus disease. In any of the 3 cases, I will have to treat the case. Are we clear about this? If I give you an example, a patient comes to me with zone 2 and stage 3. Will you treat? Yes or no? Will you treat? Yes or no? Zone 2, stage 3. Zone 2, stage 3. Zone 2, stage 3. No treatment. Why no treatment, everybody? Because it is not plus. To satisfy the third criteria, it will be zone 2, stage 3 and plus disease. Similarly, let me give you another example. It is zone 1 and stage 1 and plus. Treatment yes or treatment no? Zone 1, any stage and plus disease. The treatment will be given. Am I clear to everybody? So this is what you need to be aware of. What is the treatment? Laser photocoagulation, we already know. Right guys? Done? As simple as that. And that's all about retinopathy of prematurity in short. 4 questions, everybody. It will occur in whom, how, when will you screen or diagnose it? Number 3, what are the stages? And number 4, what is the treatment and when to do the treatment? No confusion? Done? So these are our 5 major diseases of vascular disorders done. If we understand in all the 5 diseases, the pathogenesis is same, hypoxia leading to neovascularization. And that is why the treatment in almost all the diseases is same, that is photocoagulation. Apart from CRAO, where it is an emergency, we are doing the emergency treatment. Apart from that, the pathogenesis and the treatment remain the same as already stated. The only difference is in the presentation based on the pathologies. Am I clear to everybody? No confusion? Now, to finish this group, everybody, I will just do 2 or 3 small miscellaneous diseases, you can see. The first condition which I am mentioning briefly is called as Eales disease. Eales disease is a triad of occlusion, periphlebitis, inflammation around the veins, and neovascularization of retina. Okay, this neovascularization of the retina is the most common cause of recurrent vitreous hemorrhage, as already stated. Because there is neovascularization, the treatment will again be pan-retinal photocoagulation. This should be a no-brainer. Absolutely clear, I hope, everybody. Yes? Now, apart from Eales disease, there is one other condition that I will like to mention in front of all of you. Coats disease. Coats disease, that's the name. What is Coats disease, everybody? It is idiopathic retinal telangiectasia. Idiopathic retinal telangiectasia. Telangiectasia, you understand, telangiectatic, tortuous vessels. Okay, there is no reason for it. It is idiopathic. Please remember this. This is more common in males. It is always unilateral. What are the clinical features, everybody? Number 1, most common clinical feature is loss of vision, which is painless, non-inflammatory. Number 2, everybody, strabismus or squint. Number 3, the same thing that occurs in retinoblastoma, white pupillary reflex, leukocoria. And lastly, please remember, it leads to exudative retinal detachment. Exudative retinal detachment. Am I clear, everybody? Just remember this much. There is nothing else that I want you to remember. If you remember this much, I think you will be able to solve questions on this. Okay? Exudates are occurring. leukocoria, strabismus, and loss of vision, obviously, because it is idiopathic retinal telangiectasia. Done, everybody? No confusion about this? That's all about my vascular disorders, 5 main, 2 simple disorders. Along with that, please do remember this. That ends our 4th group of diseases, everybody. Now we have to start with the only last pathology remaining in retina, that is retinal detachment. Retinal detachment is a very easy pathology. Let's try to get a hang of it.